Good afternoon, good morning, good evening, everyone. Welcome to this, our 23rd webinar focusing on gender and COVID-19. My name is Paul Ndebele. I serve as a Senior Research Regulatory Specialist in the Office of Research Excellence, and I also teach in the Department of Global Health at the George Washington University's Milken Institute School of Public Health. I would like to welcome you all to this webinar. COVID-19 has raised lots of ethical issues, right there from prevention, containment, cure, and even management. But this month, we are privileged to have some experts joining us and focusing on gender issues. This webinar is hosted by the Office of Research Excellence in partnership with the Bioethics Interest Group and our research ethics capacity programs in Bamako, Mali, and also Kinshasa in the Democratic Republic of the Congo. So as we proceed with our webinar, if you have questions or comments, please feel free to use the chat function to send those comments or questions. We'll be sure to get through them as we proceed with our webinar. And my colleagues in the Secretariat are going to provide some guidance in terms of how you can send your professional enhancement or continuing education forms for signature. Now, it is my pleasure to introduce our first panelist, who is Dr. Roopa Dhatt. Dr. Dhatt is a passionate advocate for gender equality in global health and a leading voice in the movement to correct the gender imbalance in global health. She is practicing in internal medicine, and she is particularly committed to addressing issues of power, privilege, and intersectionality that keep many women from global health leadership roles and to opening up spaces for the voices of these women to be heard. As part of her efforts, she has actually co-founded an organization called Women in Global Health. And today, this organization has more than 25,000 supporters. So now I'm going to hand over to Roopa to share with us her views on this very, very interesting and yet challenging topic. Over to you, Roopa.
Thank you, Paul, for such a great welcome. And I am so excited to be here with all of you, especially of all weeks. It's the week where the World Health Assembly is happening, and to get an opportunity to talk about gender, and especially gender in the pandemic and COVID-19 times, is exactly the type of things that I like to do and my organization is all about. So just give me a moment. I'm going to switch over to the slides. And Paul, if you could let me know if there's any issues here. Okay, great. Paul, can you see that?
Yes, perfect.
Okay. Well, I'm going to be focusing on gender and COVID-19, and that is a very broad topic. But to ground us into what's really happening in global health, the themes I'll be focusing on around really women's leadership, what a gender responsive approach in health security and health systems should look like. And then finally, also really talking about the experience of women in the health and care workforce. So briefly about women in global health, we are a global movement. We have over 25 chapters all around the world. We doubled in the past year, just showing pretty much how important working on gender equality and how much working on gender equality resonated with people during the pandemic. We are a platform for all voices, so we have majority women that are active in our chapters, but genders from all genders that are allies participate. We are catalysts catalytic in the sense we take the conversation of gender equality where it isn't happening, and also we're a strategic disruptor. When we see that conversations and policy work on gender is not taking place, but there really is an impactful moment, we mobilize through our chapters, through our partners, and through just our global network to have impact. We have over 50,000 active supporters from 90 plus different countries. We also have a DC chapter I should mention, and really invite all of you to participate in that community. So Women in Global Health, we really do things differently. For us, in gender equality is very much tied down to power and privilege lens, and we provide a tailored approach to really make sure we impact the hardest to reach and put the last women first. Traditionally, the women that are left out of dialogues are the ones that we are trying to reach and make sure that that our platform is a way for them to shape the health agenda both locally but also globally. When we take a look at the spectrum of ways to approach gender and gender equality work, for us the goal is to be gender transformative. I'm going to keep this part brief, but just to show that there is a spectrum. Organizations and programs and governments can be gender unequal and exploitative, and this is where one sex has more rights or more opportunities. Societies privilege men over women. Examples are there are still labor laws in many countries where women are prohibited from working night shifts, women are prohibited from certain jobs, and so that's an example of exploitative policies. What we are starting to see particularly in COVID-19, a lot of the policies were gender blind. Reviews that have been done globally have shown that 20% of the policies that were mapped in a policy tracker by CGDev, over 400 policies and programs during COVID-19, only 20% actually looked at gender aspects. The majority of the programs were 80% blind. Gender sensitive is the process of acknowledging the gender norms and roles, but it does not necessarily work on inequality. Gender responsive is when those needs are starting to be considered and when barriers and access to resources are being considered by gender, and there's an attempt to address some of those barriers. And then gender transformative is where there's an active effort to really go to the root drivers of gender-based health inequities and aims to foster progressive changes in power relations between gender. And for Women in Global Health, when we talk about gender transformative, we don't do it just only uniquely on gender. For us, it is very much about all the other identities that people carry, whether it's race, socioeconomic status, geography, religion, caste, ableism. And so gender transformative is very much about using a power lens, and that's where having an intersectionality approach is critical. So the power of data to understand where we were walking into a pandemic, particularly with where women's leadership stands, because that is something that we focus on in Women in Global Health. So I want you to use the chat function before I dive into the power of data and what data we do have. How many years do you think it will take to achieve gender equality? And please use the chat function to make a guess. I'm just going to see what we're seeing here. Yes, I don't see any guesses here. How many years do you think it will take to achieve gender equality? And gender equality by the World Economic Forum definition includes education, political leadership, economic, health aspects. Great, so I see a guess 35, my clue, and I see 100. Great, so a couple more guesses coming in. And I have to say, Professor Adnan, practically 25 fears 50. Okay, so you provided a range, very, very academic in nature there. So actually the estimate is it's going to take 135 years per the World Economic Forum to achieve gender equality. This past year, we have seen an increase of almost 35 years, let alone because of the pandemic and the setbacks and the projections related to those setbacks. So when we take a look at the field of global health delivered by women, led by men is how we describe the field. And briefly, what we are showing here is a leadership pyramid that Women in Global Health creates every year to look at the latest data on where are women in the health sector. So again, they're majority in the health and social care, in the long-term care workforce. When it comes to political decision-making or being the head of academic institutions or global health organizations, these numbers range from 25 to 30% and really don't break that 30% ceiling. And then in the private sector, women lead less than 5% of Fortune 500 healthcare companies. When we look at the World Health Assembly, and this is data from last year, we're going to be releasing the data from this year just tomorrow, but we've mapped out what does women's representation, political representation look like. Only 23% of World Health delegations were led by women, and what you'll notice is that there's certain continents that are doing a lot better, particularly the African continent has a track record in the last few years of having more representation. Many of the countries there have made it legislative to have women in political leadership. Many of the head of states of these countries have adopted 50-50 cabinets, whereas we know there's certain regions that continue to struggle, and a lot of that includes Eastern Mediterranean, but also parts of Asia. The numbers in the last 15 years haven't changed beyond 25% range. They peaked at 31%, and we just haven't been able to, again, break that 31% ceiling. A work done by another organization called Global Health 50/50 looks at global health leadership particularly, and they have found that less than 5% of global health organizations are led by women from lower middle income countries. They also have shown that majority of the leaders of global health organizations are from the UK and USA. And that, comparing that to the contrast that 83% of the world's population is based in LMICs, the majority of the global health programs are focused on these communities. This is, again, a power and privilege lens in global health. Looking at deeper issues, global health is still built on unpaid and underpaid work of women. Half of what women do in the health sector, which is about 1.5 trillion US dollars annually, remains unpaid. The numbers are that this has gone up in the past year and will continue to rise given the shocks of the pandemic. When we take a look at global health programs, and I'm highlighting two, how many of them actually link their SDG 3 work, which is the Sustainable Development Goal on health and well-being, to gender. If we look at UHC, particularly universal coverage, only half of those programs have a gender component. If you take a look at health workforce itself, less than third, or only 1/3 of the organizations actually have a gender component to their work. So now shifting focus to the gender transformative action, and really COVID-19, Women in Global Health launched a campaign called COVID 50/50, a campaign for gender responsive health security during the COVID-19 pandemic. And our effort is to influence at multiple levels. This is our theory of change. And again, for sake of time, I won't go into greater details, but what I want to focus on is that we at Women in Global Health target governments, which are often member states in the global health governance architecture. We provide technical assistance. We shape the policy language through influencing other actors that have the means to shape the language on global conventions and commitments. We also acknowledge our agencies that have really made progress on gender parity, which is having men and women in equal leadership roles, but also having diverse gender transformative leadership and advancing the broader agenda. We use our chapters to mobilize at the national level. So in COVID-19, Women in Global Health organized through our movement of partners and chapters over dozens and dozens of conversations around gender equality and the various aspects of it, from health workforce to the pregnancy implications. So the work I'm representing here is really not just the work of myself or our global team, but really a global movement that is based across the world. What we felt when I asked for global health security to be gender responsive, we narrowed it on 5 areas. This is not meant to be comprehensive. There's a lot more to really having a gender responsive approach. But for us, these were the gaps that we kept seeing over and over again. One, really making sure that women are represented in global health security decision-making structures and public discourse at all levels. Second, really providing health workers, most of whom are women, with safe and decent work conditions. Number 3 is really recognizing the value of women's unpaid care work by including them in the formal labor market and redistributing unpaid family care equally. Ask number 4 is about a gender responsive approach to health security data collection and analysis and response management. Again, a lot of the data that was being collected early on was not disaggregated by sex and gender. Many aspects of the response continue not to have sex and gender disaggregated data. And again, most of the policies that have been passed to look at to respond to the pandemic have again not been gender responsive. And our ask fifth is unique to really women's movements. Women's movements have built a lot of resilience at the community level, yet less than 1% of overseas development assistance that goes to gender equality gets into the hands of women's organizations, and less than 0.17% gets into hands of women from LMIC. So this is what our call to action is based on, and it is based on responding to the evidence that we started seeing from our chapters, our networks of health professional associations, an example of unpacking what was happening to women in health and care work. And again, this is a theme you're going to hear a lot about this year because it is the year of the health and care worker by WHO. And I know GW also does a lot of work on health workforce, but from a gender perspective, what we were hearing is that again and again, while majority of the response at the front line in some countries, up to 90% of the frontline response was by women. So even in Wuhan, when COVID first broke out, 90% of the health workers taking care of patients were women, but yet they are left out of leadership and decision making, even though they know the health system's best. Many of them faced high risk of infection. The limited data we do have on health worker infections show that 70 to 80% of the health worker infections were women. We know that some of the reasons of why that was happening is because of inadequate access to PPE, but also not the appropriate size PPE, not factoring in the menstrual needs of women, so not giving the appropriate dignity. We also know that there was safety at work, increased attacks were happening in some countries. There was bleach being thrown since health workers were seen as vectors of disease. They were also, facing some of the broader increase in gender-based violence that has tripled and quadrupled in the pandemic. Increased mental stress. There was fears of risking infecting family, especially vulnerable relatives, but also children, stigma in the households, and then also fear of financial hardship. Many of the women healthcare workers and around the world, especially in low resource settings, were unpaid and underpaid. In India alone, 1 million ASHA frontline health workers went on strike because of the earnings and lack of decent conditions. Again, managing childcare and homeschooling while being a health worker, long hours, long shifts without really being supported. And again, while there was a lot of applause, very little of that applause turned into real investments. So I know I'm coming nearly to an end in this presentation, and I'll just breeze through some of the next key points. We have data confirming that 85% of national COVID-19 task force are majority men. So while women were recognized head of states for being successful at managing the coronavirus, again, women power is not being used at all levels in the health sector. This data shows, and I'll make these slides available so you can unpack some of the regional data, but what is noticeable is that even regions that traditionally do really well, like the African continent, when it came to COVID-19, more than 90% of their task teams were majority men. So again, we are seeing the pandemic worsen through these gender dimensions. At Women in Global Health, we launched an effort to increase visibility of women's leadership and crowdsourced expert lists. And some of the other gender blind decisions as a result, WHO did a survey looking at which health services were disrupted. 30% of countries reported that maternity and reproductive health services were viewed as not essential, and they were disrupted in many countries. But we know that pregnancy does not stop in the pandemic. I mentioned the personal protective equipment being modeled from male bodies, even though majority of the health systems are run by women. So again, this is a mismatch. Lockdown policies and put women and children in unsafe homes, and sharp increase in domestic violence everywhere. And these are examples of gender blind policies. If you'd like to learn more about the data, we do have a report available on our COVID 50/50 website, which covers a lot of the issues affecting women, especially in the health and care sector. And we are calling for a new social contract to really rebalance this. Some of the key messages here are that COVID-19 is a global wake-up call to build back better, build back new, or build back, just more equitable systems. And the women who deliver our health and social care deserve a new social contract with decent working conditions and equal role in decision making. And if we look after health workers, they will keep us safe. And that is, one indicator of our health systems on how gender equal we really are. So on that note, I turn it back to you, Paul, and invite all of you to join the Women in Global Health movement.
Thank you very much, Roopa, for taking us through the work that you are doing through Women in Global Health. You have stressed so much on the need for women to take up leadership positions so as to play some influential roles leading to gender equality. We've also discussed issues around power and privilege. And I was particularly saddened by the figure that you mentioned of 135.6 years. That's scary. But we're going to discuss later on what we can do to ensure that we contribute in different ways in reducing that figure. And I also use the power of data to illustrate all these ethical issues around gender and COVID-19. So thank you very much. Once again, I want to invite our participants to send through questions using the chat function. Now I'm going to introduce our second panelist, who is Dr. Mary Ellsberg, is one of our own right here at the George Washington University. And Mary is the founding director of the Global Women's Institute at the George Washington University. She has more than 30 years of experience in international research and programs on gender and development. And before joining George Washington University in 2012, she served as the Vice President for Research and programs at the International Center for Research on Women. And before then, she spent some 20 years working in Nicaragua on women's rights issues. And she's a member of the core research team of the World Health Organization's multi-country study on domestic violence and women's health. And I hope that Mary is going to share with us on issues around COVID-19 and gender violence. So over to Mary. Thank you.
Thank you so much, Paul and Adnan, for inviting me, and especially to Roopa for that fantastic overview of the myriad ways that the COVID pandemic has affected gender equality and reinforced inequality and has set us back. I'm going to focus on one of the very specific issues that Roopa touched on, which is violence at home and violence against which primarily affects women and girls. Recent figures that were put out by the World Health Organization showed that about 1 in 3 women experiences intimate partner violence, physical or sexual partner violence from during their lifetime, and another 7 to 10% of women experience non-partner sexual violence also during their lifetimes. And this is a pretty new area of research. Before I went into that, I wanted to say just a little bit about the Global Women's Institute, if you're interested. We do training, online training called Gender Pro. It's a professional course on, it's a course for professionals to learn more about how to use gender analysis in development projects. And there's a special track on global health. We also have a credential called the Gender Pro credential for professionals who are working in the field to upgrade their skills and also to be able to have, it's the first professional credential in this field. So that might be something that some of you will be interested in. We mostly do research on gender inequality and policy work and women's empowerment. But my particular background for the last 30 years, as Paul mentioned, has been research on violence against women and girls. And this is a pretty new area of research. It's really just began in the last 30 years and has taken off more or less in the last 20 years. One of the largest initiatives, now let's see how I can do this. Let's see, there we go. Was the multi-country study developed by WHO on women's health and domestic violence against women. And this was a study of 24,000 women in 10 countries. And I was privileged to be part of the team that designed the study and implemented it. It's still considered the gold standard and is used around the world. And now there are about 150 studies, population-based studies on violence against women, whereas when we started in the late 90s, there were less than 30, and they were mostly pretty small scale. So as we started doing this research, we realized that the standards for how to do this in a safe way really didn't exist. Early on, we realized that women were often afraid to talk about violence, or we would find out that if we weren't really addressing their safety needs, women were at risk of suffering more violence by an abuser as a result of having talked to us to the researchers. And so a big emphasis of ours over the last 20 years has been to develop safety guidelines for doing this kind of research, both on domestic violence, and now we've developed guidelines, a host of different contexts, including conflict and humanitarian sector. There are ethical guidelines for doing research on perpetration of violence and violence against children as well. But the bottom line of this that we always insist is that the consideration of the safety of the interviewer and of the respondents has to guide all project decisions. And if we can't guarantee that the basic measures are going to be put in place, then we shouldn't carry out the research. And so ironically, particularly in the early years, we were often in the position of trying to close down research projects that were interested in studying violence against women, but they were doing it in ways that we felt were going to put women at risk. So let's see how to do. I don't know why I'm having trouble with this. There we go. And one of the main ways to avoid that is by making sure that you have significant participation from local experts, community leaders. We always have technical advisory groups who can guide us on how to do the research safely, making sure that the questions we ask are appropriate, and most importantly, to make sure that there is uptake, that we're able to use the research at a local level for improving gender equality and reducing violence. So this is an example of our advisory group in Juba during a study that we did a few years ago in South Sudan, a prevalence study. And there are several basic, the basic principles are the same as in any kind of research, but it's how do we minimize harm both to respondents and to the researchers. And as I said earlier, the most obvious harm would be physical harm as a result of disclosure. And very literally, this can be an issue of life and death for women. A woman who is being abused by her partner, who finds out that she's been talking about it. We've heard cases of women being severely beaten, being chained up, being shut in their houses as a result. But in addition to that, there's the psychological harm of re-traumatization. And this is something that IRBs are often very concerned about, that just thinking about the violence and reliving it can also be very traumatic, and we need to be prepared to minimize that and respond to it. And finally, the social harm of stigmatization, and that if community members or others find out that a woman is being abused, this could lead to bad outcomes for her as well. And then something that was not really well understood until we started doing this research and getting deeper into it is the potential harm to researchers. Of course, the harm of going to a woman's house where there's an abusive husband, and sometimes often the research is done on weekends or at night, and making sure that we keep our interviewers safe. But there's also the vicarious trauma, the psychological harm from listening to just day after day of stories of terrible violence and degradation that women have gone through. And it can also often cause the researchers or field staff to relive their own experiences of violence. And in countries where 30 to 50% of women have experienced violence, that means that the field team also has experienced a lot of violence. So some of the ways that I'm going to talk about some of the measures that we have been using. And the first one, obviously, is total privacy. And this is unlike, for example, in the demographic and health surveys, a big conversation we had with them was that interviews are usually done with all women of reproductive age. And it doesn't really matter if others are around or children are coming in and out. There's an interest in privacy, but it's not absolutely essential. In our case, we don't even allow children to be in the room because we don't want, men coming home and having the children say, Daddy, guess what mommy was talking about today? So we always make sure that there's total privacy. And sometimes that means going outside. It means accompanying women while they're doing washing or other daily activities to make sure that we can be alone with her. And we also have, our supervisors are always attentive to if children come home from school. This is, for example, a supervisor who is playing with a child who just came home so that her mother can continue to carry out an interview in privacy. And sometimes we have coloring books or toys or other things to keep them distracted. If anybody comes into the room, we either use a dummy questionnaire, so we use alternative questionnaires about breastfeeding or vaccination so that nobody will know what the research is about. And if they refuse to leave, then we cancel the meeting and try to set it up at another time. So these are some very concrete ways that we minimize risk. One of them is we never tell anybody except for the woman we're interviewing that this is a study that is about primarily violence against women. We present it as women's health survey, women's life events. We only interview one woman per household, so we always do a random selection of eligible women, and we interview only one woman so that others in the family will have less opportunity to find out what the content of what the subject of the research is. We have several opportunities for informed consent, not just at the beginning, but every time we enter into a new and potentially distressing conversation, we repeat the informed consent, make sure she understands that she can stop at any time if she's feeling uncomfortable or feeling upset. We don't interview, although it would be very interesting to have both the versions of men and women in the same household, for example, about what kind of violence is happening in the relationship in the household. We think that the cost of that, the risk is too great. And so we don't even interview men, not only not in the same households, but not even in the same clusters. So when we do interviews that involve men and women, we have completely different sampling frames. So that it doesn't get out quickly what the study is about. And then finally, we make sure to always give information about violence and local laws and referrals for specialized care to all of our respondents. And we always ensure that there is some kind of referral mechanism in place. If there isn't one, we set it up. If we can't set it up, then we don't carry out the research in that area. So this is an example. This is a women's health center in Papua New Guinea. So by giving information and referrals to counseling, again, we are taking active measures to reduce any distress to participants. And in some cases, for example, in South Sudan, we went much farther than that. We were working with the International Rescue Committee, and in order to ensure that we had GBV counselors available, we put that into our budget, the counselors, because IRC's funding is often very short term, and they had excellent trained counselors, but they had just run out of funding. So we funded that for the period of our research. And we also had cards that we could give everybody with a phone number. And the car is important because it's very difficult. There's a curfew in many of the towns that we were in, and women wouldn't be able to leave their homes if they were having a problem with violence. So they could use the 24-hour hotline, and we had a car and a counselor available 24/7 who could actually go to their house. That's very unusual, but this was such a special situation that we wanted to make sure that we were really being very careful. Another very important issue is selection and training of interviewers. Our training typically lasts 3 to 4 weeks, which is much longer than most interviewer training, but it's because we spend a lot of time talking about gender, gender stereotypes and violence, and how to behave, how to both prevent crises, and how to behave or how to react if a woman has a crisis during the interview. A lot of role playing, and we always bring in many more interviewers than we're going to use, because we found that the quality of the interviewer and his or her ability to develop empathy and to listen in a non-judgmental way is so key that we choose only the very best of those who have been trained. And in South Sudan, in conflict situations, it can get even more complicated, as we were doing a survey of both men and women, and in different towns with different ethnicity. It meant training several cohorts of interviewers who spoke the languages, but also, because there's an inter-ethnic conflict going on at the same time, who were able to travel and mobilize in those areas without risk. And then finally, as I mentioned, the issue of vicarious trauma. And this is a quote from a woman in Nicaragua who was part of a DHS. She was not in one of our studies, and we did debriefing afterwards, and she talked about how hard it was to listen to these stories and then be expected to just go back into the next house, and she'd find herself bursting into tears during the next interview. So we also have debriefing meetings specifically for self-care. We do lots of different kinds of relaxation activities and others just to help keep the interviewers, to help them withstand the enormous pressure of doing this kind of research. And we also always have psychological and counseling services for the researchers and the staff during the data collection. We have some data, for example, on South Sudan. When we went through this with the IRB, it was the first study on violence that we had done at GW, and there were a lot of questions in the IRB of, can you even do this study? Why are you doing it at home? Why don't you bring women into the clinic? The fear that women would be, disassociating, that they would be going into, really traumatic crises. And so we kept track of the adverse events. And one thing that we have found is that women really appreciate talking about this. Often it's the first time they've ever been asked about violence. And often it's the first time they've ever told anybody, even family members, about what they're experiencing in their relationships. So even if sometimes they start to get a little teary, we always have tissues with us, or they need to take a break or have a glass of water. For example, 0 women dropped out during the violence questions of the study. And only 1% of our respondents, the female respondents, declined to participate and said it was because they were afraid of violence. They thought that it would be dangerous for them to talk about it. We also kept track of the services around in the area to see if we were going to see a spike of services for violence as a result of the study, and we did not see any increase in services. And then at the end of the study, we asked women how they're feeling, after having talked about this. Do they feel worse, the same, or better? And almost 100% of the women felt either the same or better. And in 4 of the 5 groups, more than 60% said that they felt better. They would say, I feel relieved. I feel that a burden has been taken off of me. So it was actually a very empowering experience for them. In one site, 4% of men felt worse. And the indication here was they were talking about perpetration of violence, both non-partner rape as well as partner violence. And in that conversation, some men felt remorse and said that it had made them think about it and that they felt bad about it. But it was not a question of being harmed by it. The other piece that for us is really important in terms of ethical conduct of research is making sure that we are using the results for change. So we always build into our budget and into our plan, both local and national and international events where we can show the findings and really try and give recommendations that will improve local programs or laws. This would be the one here is in Honduras after a study we did on addressing violence in pregnancy in the health sector. The other one is at the Commission on the Status of Women, where we regularly present as well on our findings to try and support more investment and support for prevention of violence. And then just the last little piece on that is, in addition to doing policy briefs and research papers, peer-reviewed papers, we also think it's really important to give back to the communities. And how do you do that in a way that is safe, particularly when you're talking about such a difficult issue? And in South Sudan, which has up to very recently been really going through a very difficult and prolonged conflict, almost gone on for decades, but the most recent conflict has been since 2013. We decided to work with IRC and CARE to have a workshop, a national workshop of local activists to explain to them, these are the basic findings we've had. Do these feel true to you? What do you think are the important messages that you could use for education in your own communities? And we invited a group of local artists, an artist collective, to join us and try to develop graphics that basically described our research. And this is what we ended up doing was a toolkit called the Safe Community Toolkit. And it talks about unsafe practices and situations like this one, which is a cattle raid, which was very common in one of the areas we worked in, where girls were often abducted and forced to marry their abductors. And so then the alternative would be encouraging community members to think about what would it take to have a safer community.
1 minute.
And so this, yes, time to end. Were you sending me? I'm on my last slide now. So I just want to say something about COVID, and basically I wanted to give you this background of how complicated this kind of research is ethically done under normal circumstances. And there is a lot of debate in our field about how to address the additional challenges presented by the COVID pandemic. So as Roopa mentioned, there's evidence that there's increased risk of violence at home as a result of the pandemic, but it's mostly anecdotal. And we'd really like to have more data, population-based data, but there's a lot of concern about conducting research because now that abusers are going to be home at the same time as women, there's additional ethical and safety concerns. And there, as I say, there's debate about this right now. And some people feel strongly that we should put off any kind of population-based research until the acute phase in the country is over. And others feel that using remote or SMS research can be helpful, although it's mostly been used in high-income countries as opposed to low and middle income. So I will stop there. We have a bunch of resources on our website that you're welcome to look at that address these areas in more depth and have toolkits.
Thank you very much, Mary, for taking us through your talk where you're focusing on issues around gender violence. And I think that your talk actually built onto the talk by Roopa, basically by giving some practical strategies that researchers who are interested in conducting research on gender violence should actually use. So for me, when I'm wearing my other hat as a GWIRB member, these are some of the strategies that I'm looking into and hoping that researchers can actually use to ensure that at the end of the day, the respondents, being women, are safe, but also that women in general are not harmed also by the results that are going to come or the findings that are going to come from those studies. So thank you very much for that great talk, which was full of practical strategies. So now I'm going to present some questions to both presenters. Some of the questions have been presented through the chat function, but I'll still encourage the participants to send in some more questions. So one question directed to Mary is, how did these ethical issues change during COVID-19?
Yeah, so I think that I addressed that a little bit in my last slide. And I think it's really just that it's difficult to be able to have complete privacy and confidentiality in this kind of research in any case, and doing it in the context of COVID is nearly impossible. So I think, as I said, I think that many of my colleagues believe that it shouldn't be done. And this also happens during conflict, during acute conflicts. Often we say that it's also not the priority. The priority is to get services to women and to make them, so from a policy perspective, what we most want is to get services to women, shelters, considering those services essential services, and making sure women have access to them.
Thank you very much. I'm going to focus this one on Roopa. So there is one of the participants who has highlighted the role of culture and religion in perpetuating gender inequality. And the participant is very, very doubtful that equality will be achieved. So what words can you say to this participant?
Yeah, well, that's an excellent point, and it is one that we are constantly, thinking about when we're advocating for any aspects of human rights and gender rights specifically. And so, how we're approaching it and why we use the gender transformative leadership approach is one, that acknowledging that it is a work in progress, so that it's not just one day we'll have gender equality and we're done. It's constantly a work in progress, a constant struggle of both aspects of gender equality where there are progressive achievements while there are also rollbacks, and it doesn't matter which country you're in, it is a constant struggle. I'm here in Washington, D.C. in the U.S., and I can say the last, a few years with the previous administration, there was an active effort to roll back a lot of the women's rights and gender equality agenda, not only domestically, but also globally. So that's an example of a constant struggle. So that's one thing to keep in mind. The second thing is to also approach gender equality from the different levels of influence. I saw that there was a question there about, do we go for, dramatic, overall change, or does it happen, in sort of tiny steps in a way? And we use the ecological model to argue that, there's individual factors where it is how an individual perceives themselves based on their gender identity, and their own ideas of gender norms and roles. So this is often where we hear that, women don't have as much confidence. Well, we know society has created these environments where women do lose confidence, but those are individual factors. Then there's interpersonal factors where we know that it is, the amount of sexual harassment that's accepted in most of the health sector. Any surveys that have really looked at this data have shown at least 30%, but some countries have shown 50% of medical trainees have experienced some form of bullying and sexual harassment. So those are interpersonal factors. Then there's institutional factors, and those are policies which I alluded to a little bit about the structural barriers that don't necessarily create the fact that paternity leave doesn't exist, but there's maternity leave in some organizations means that women are always the ones that are going to have to take the care responsibilities in households with children and in family homes. And so these are all examples of there is processes across community all the way down to individual, and we do need to approach it really from this place of constant negotiation. And for the the point of will we ever achieve gender equality, I'm very confident we will if we continue to change our mindset and especially work with the next generation. Every generation has an opportunity to not be shaped and influenced by regressive gender norms and roles. And each society is always constantly evolving. Culture that existed a century ago is different. And so I think that, for us to say that, humans will not progress, I think it's a bit too defeatist. And I'm sure all of you that are working in global health do bring strong ideals of equity and human rights. And so it is a work in progress. It's not easy. Those projections that jumped 35 years just by 1 year of setbacks just shows that there's also the potential to reverse the change and actually leapfrog, I would say, not even just by a few years, but by decades, if we start doing and implementing some strong programs and policies. But finally, it is what happens in our households and communities. So continue the conversation and really making sure that we keep addressing the root drivers, which are often gender norms and roles.
Thank you very much. And you've actually responded to the other question that I was going to ask you about whether you are going for the fundamental shift or the incremental shifts. So you've basically demonstrated that through small steps, we are going to get there eventually.
Yeah, and Paul, I'd say that there are some fundamental big changes we can do. And I talked about the unpaid work, for example, that happens in the health sector. And it's almost the sort of one of the top things that are ignored. We know that many countries are dependent on volunteer or stipend-based community health workers who are majority women. And if there was an effort to formalize and acknowledge these community health workers, bring them into the health system, give them living wage, that would be a fundamental shift in how we perceive women's contributions in the health sector and start putting value to it. We've seen that happen in countries such as Liberia did that, but it was not done in a gender transformative manner or even gender sensitive. So what happened was that initially there were more women community health workers, and then it flipped over to being more male community health workers once the jobs became formalized. And then there's a country like Ethiopia, which has placed a little bit more emphasis on gender, and we've seen that the effects of women's economic empowerment there have really increased because of keeping the women that were community health workers in the formal health sector, not necessarily just creating new jobs for men. And so I think that's an example of where you can have some really big wins. But a lot of the work does need to happen in at the community institutional level to really bring transformation.
Thank you very much, Roopa. Now I want to go to Mary. To you, Mary, I'm coming back to you with the question around the 135.6 years. I'm so worried about the 135.6 years, knowing fully well that COVID-19 has actually contributed by adding more years, right? So before COVID-19, we're looking at a slightly shorter period, but now with COVID-19, we have added more years. And now we're talking about 135.6 years.
Right, okay.
So for you, coming from the Global Women's Institute, I want you to think about what we within the universities, academic institutions can do to contribute towards the shortening of that period. I'm worried about this 35.6 years. What can we do as universities to shorten this period?
Well, from my perspective, I think it's doing a big piece of it is doing evidence-informed advocacy, which is exactly what Roopa is doing. I mean, the presentation she gave shows the results of so much important research and making the case, for example, to the UN, to the World Health Assembly, about the policies that need to change. So I think to a large extent, it's structural changes that we need, improving women's leadership, taking care of the setbacks they've had, being forced out of the economy, and subsidizing and supporting the care economy, et cetera. But as everyone has mentioned, we also need cultural changes. And one thing we found out in prevention of violence against women work is that it is possible to prevent violence. And the main way to do it is by changing social norms. And As you mentioned earlier, I've spent many years in both living in Nicaragua and studying violence against women in Nicaragua. Recently finished a 20-year follow-up study that showed that violence was reduced by 70% over a 20-year period. And when we looked at what are the major factors that did it, they all come back to basically feminist organizing. The women's movement in Nicaragua had a very strong program of teaching women about their human rights. There was a program also of men organizing to change their, machista attitudes and notions of masculinity, and just talking about other ways to settle conflicts and to balance power. And that was a very significant contribution to all of this, in addition to the laws and the policies. So, Roopa talked about an ecological approach, working both at the individual as well as the community and the national and global levels. And I think we really do need to work at all those levels. And, I encourage both students and faculty to engage more in this kind of research and advocacy.
Thank you very much, Mary. I'm coming back to you again with another question. So, focusing specifically on gender violence studies during the COVID-19 pandemic, what is your take on the research that has been conducted so far, focusing on gender and violence during COVID-19?
Well, there's been a lot of documentation, and there, many articles have come out now looking at the impact, but it's mostly based on service, on reporting to services. So it's, calls to helplines have tripled, calls to, for shelters, for example, and hotlines all over the world. In most countries, we've seen very large increases. In a few countries, there have been decreases, and the suspicion is that it's because women don't have access to the technology to be able to ask for help. So what's hard with service data is that what you don't know whether it's the same but has just gotten worse, or women are now more likely to report it. So in the absence of population-based data, it's hard to say whether it's gotten more, or whether it's actually increased, or whether women are just speaking out more. I think what we're going to end up finding, just as we do in conflict, we usually look at the impact of conflict retrospectively. So we're looking at women or child sexual abuse. We talk to adult women about experiences they had in their youth or childhood. In conflict, we talk about experiences they had during specific conflicts. I think we'll be doing a lot of research now that is talking about these issues. Has it ever happened? Did it happen during the COVID pandemic? And did it get, did it start then? Did it get worse or better? And that's probably the best way we'll be able to approximate and find out what really did happen.
Thank you so much. Now, because of time, I'm now going to give our panelists some 35 seconds to give your last words. So I will start off with Roopa.
Great. Thank you, Paul. The time went by so quickly. So my message to all of you is that, one, gender equality is really everyone's business, and it benefits all genders, and it benefits society. It results in a triple gender dividend. So when we invest in gender equality, especially in the health and care workforce, we're going to see a health return, achieving our Health for All agenda. We'll see an economic return. Projections show when we have gender equality, we'll achieve at least 160 trillion increase in human capital, which is the GDPs of many countries added up together annually. And then we also will see a gender return. So women's economic empowerment means that they're going to be able to participate more equally in society. So see this as an investment for all genders. Thank you.
Thank you, Mary.
Yeah, I think that Roopa's point that gender is everybody's business is really the key one. And for both students and professionals, that means that the strategy that we've used for so many years of having a gender advisor who was in charge of gender equality, and often our analysis, our programs end up being not even gender blind, but gender harmful, because people treat it as something that you sort of add gender and stir after you've already developed the whole program. So as professionals, as students, we really need to learn the tools of gender analysis, which are not rocket science, and integrate them into all program planning and evaluation.
Thank you very much, Mary. Thank you very much, Roopa. And thanks to all the participants in this webinar. Thanks to those who posed some questions and also some comments. Thanks to everyone for listening. Thank you for attending this webinar. We look forward to you joining us again for our next webinar. We're going to send information about that soon. So thank you very much and bye.
Bye.